It is 12:31, and I want to be sure to give Dr. Kim sufficient time to talk with us today. First of all, this new KN95 mask, I'm going to go back to my knockoff KN95 because this one hurts my ears. So if I pull up my ears, it's because my mask is really bothering me. I am incredibly happy to introduce today's speaker for seminar. Dr. Kibum Kim is a graduate of the PSOP PhD program. Following his completion of his PhD, Dr. Kim spent several years at the University of Utah as a research assistant professor and then an assistant professor, and has joined us. He's come back home and has joined us in the College of Pharmacy here at UIC as an assistant professor. And Dr. Kim is going to talk with us today about the kind of research he's done and is interested in doing. So without further ado, I am going to turn it over to Dr. Kim.
Okay, thank you so much for the welcome remark, totally. So, the half of my today's presentation is about research, but the rest half is not about the research. It's about my life and how I develop my research idea based on my life. So you can just leave away and enjoy my presentation. Hopefully you can. So today the topic is, how does your life or my life help me have my own research idea? Okay, so actually, after I design my slide, I just make a mistake because there is the clock inside and I'm sitting outside of this window. So it should be flipped. So anyway, yeah. Okay, before going over my presentation, I just want to briefly introduce who am I and what I'm doing right now. So before I entered this program, I graduated from the College of Pharmacy in Korea. So basically, I had a background in some kinds of the clinical science and the clinical practice as a pharmacist. And then after I graduated from my Bachelor in Pharmacy program, I did some research in training for the pharmacokinetics and pharmacodynamics. Yes, he looks young, but not right now, but yeah. And then after I completed this Master in Pharmacokinetics and Pharmacodynamics, I actually worked as a pharmacist. So 3.5 years of the practice experience, because I was interested in studying. Since then, I was interested in the studying in the health economics and pharmacoeconomics and outcomes research. So, but Korea was not that much developed country in this study area. So I dreamed study abroad. So I made money and then studied here for 5 years. Finally, I got a degree in the PhD here in 2016, and the picture was actually coming from the 2017. So, I'm planning to do some kinds of the YouTube clip. Yeah. So this is the doodle, and I purchased this one at the beginning of this year around the $70. It's just kind of the entire over the rest of my life. So I'm going to use this one for my next presentation and next presentation and next presentation, if I can. Yeah. So, yeah, so for this 10-second clip, you have to work for an hour. That's the thing. So basically, I had a variety of experience in, excuse me, what is that?
I'm trying to let him in. I got it.
Okay. So I had a variety of different types of research and training experience in analytical validation, because to run some kind of pharmacokinetics and pharmacodynamics, you have to learn how to analyze your sample. And then preclinical and clinical study. This includes bioequivalence study as well as some kinds of the phase 1-2 clinical trials. Then I also had experience in the clinical practice and patient engagement, then completed outcomes research training. So because I had really unique research journey, this variety of training helped me understand multiple different kinds of the way to understand the science. So this is the study I published in 2019. So the title of this study was Cost Effectiveness of Therapeutic Drug Monitoring for Imatinib Administration in Chronic Myeloid Leukemia. And this is kind of the TDM program, Therapeutic Drug Monitoring Program. So the sponsor, not institution, so sponsor laboratory was interested in how to make a linkage between the pharmacokinetics profiles into the pharmacodynamics profiles and how they can make a link from PD data to the health outcomes. So everything was based on the mathematical model. And because I did the training, so I understand how to build it. So you can see the dose and pharmacokinetics association and the pharmacokinetics response and association. Then it was embedded into the Markov model to run the cost effectiveness simulation. So basically, if you experience some kinds of a ton of different kinds of the areas as a part of your research, it helps and it can help you build more and more on top of everything else. So while I was there are a ton of projects I managed over the last 5 years in the Utah, and I had some experience in the opioid management and the chronic condition management in the cardiovascular disease and the diabetes. And now I started to develop my own research career starting from this multiple research project. So there are 3 main areas I am currently interested in. So for example, leveraging machine learning to enhance electronic health record data, cost effectiveness of AI-driven kidney function prediction. So those 2 are related with AI-driven or machine learning-driven technologies incorporated into healthcare system. And then the rest of the study, the rest of my research area is definitely related with how to manage chronic conditions and how to run the traditional outcomes research across the multiple different kinds of chronic conditions like cancer or cardiovascular disease or diabetes. And then the rest part, cancer instance healthcare cost and resource utilization in immunocompromised patients and the clinical utility of the congenital disorder screening, those 2 are highly related with how to utilize bioinformatics from the perspective of clinical utility. So I'm going to jump into the discussion on what is the meaning of the clinical utility and why this is important. Okay, so clinical utility means value of diagnostic or screening test in a clinical setting. Yeah, probably majority of you or all of you understand what does utility mean. Yeah. Utility means everything you love to do. So like state of being useful, profitable, beneficial, functional. From economic perspective, it can be a preference or it can be kind of used to utility can be used to a model worth or value of some techniques or services. To pay attention to clinical utility, I'd love to emphasize 3 different words here: useful, functional, value. Meaning that a diagnostic test has utility in a clinical practice when it potentially influences and improves clinical decision. So basically, a test has utility when it changes clinical decision. So you can see now everyone used the COVID test, and the COVID test has a 100% utility because based on the test result, you are going to be in quarantine or you are going to receive certain kinds of treatment. So test result directly influence clinical decision. So value of the test in supporting clinical decision is the meaning of the clinical utility of diagnostic test. And definitely it is a concept beyond the diagnostic accuracy, and it is actually required to be cost effective. Yep. To demonstrate the cost effectiveness of the diagnostics or the screening, then there are 3 basic processes. So analytic validity, which is kind of the sensitivity of your test and specificity of your test from the biological materials like blood, urine, or feces. And then after that, that analytically valid test should have demonstrated its clinical validity. It should be associated with certain kinds of the diagnosis or the prediction of disease or the future progression of the disease. Then, once that has been completed, then now we have to think about the clinical utility. Does it meaningful for the clinician? Does it change the clinical decision? That is the key part for the cost effectiveness assessment. But interestingly, if you take a look at a bunch of the studies published in the PubMed or any kind of the journal, what you can find is that, okay, basically we are running this cost effectiveness model with assumption that this test has been utilized in the clinical setting 100% of the clinical utility or the 80% of the clinical utility. So that was basic assumption in the cost assessment in the model-based approach. So we probably have to think about what is the dynamics of the clinical utility. Interestingly, lack of clinical utility data, meaning that how this has been utilized in the clinical setting, is lack. So is the most commonly cited reason for why companies fail to receive favorable coverage decision and the reimbursement decision. I mean, basically, this is catch-22. If you see this slide, limited or lack of outcomes data is not fully covered by the health plan. So if it's not covered, you cannot get a utility data. If it does not have utility, it's not covered. So it's kind of the catch-22 issues for the company and the health plan. And so if there's some kind of the issue on the increase in the medical resource use, then definitely it's not going to be compensated by the health plan. But you know what, there's not enough way or not sufficient way to demonstrate is it valid or is it utilized? We don't know. So there's no chance to obtain the utility data without usage or coverage. So a lot of studies use model-based economic assessment approach because lack of data. So there was an interesting publication written by me. So when I started my position at the University of Utah, this was one of the first study assigned to me. And it was actually the NCT registered randomized control trial. And originally somebody else designed this study and they collected data. And I just realized that, okay, this design was not so much great to run. So I actually modified this study and the collected data, the data collection has been completed by my research team. And then it demonstrated the clinical utility of the pharmacogenetic testing and the clinical decision supporting tool in the polypharmacy patient. And the theoretical frame here is that, okay, once this one has analytic validity and it can be linked with the clinical validity in predicting grade 3 or higher grade serious drug therapy problems, then it will be utilized. And this concept has been demonstrated in the pilot level clinical trial data, and it's well published. And probably, you know, so you can see this pathway is similar to the 3 arrows I presented a couple of minutes ago. And yes, this happens. So, I mean, you know, this is, I think this is 2 minutes or 2.5 minutes video clip published by the AJMC. So when they invited me, so they actually sent me 5 different kinds of questions. So I actually interviewed with them for 50 minutes and they only picked 1 out of 5. And this one discussed about, okay, this is the situation of the polypharmacy and the pharmacogenetics, and the rest 4 was about the clinical utility, but the rest 4 was not published, and this one is posted. You can find it from the YouTube. There's a, I mean, you can just search it, Kibum Kim, clinical utility, JMCP, then you can find it. Okay. I mean, pretty much everyone understands that I'm the most productive faculty member here in this department, and I have 4 kids. And I mean, my life journey of having these 4 kids actually direct me toward generating some kinds of research question associated with the clinical utility of the diagnostic testing. So this guy, Aiden, who was adorable. Yeah, he's 7-year-old, and now every day he says no. But I mean, it's understood it's kind of his age. So when we have, when my wife was pregnant for Aiden, my first son, there was such kind of the traditional mechanism to follow for the prenatal checkup. Like once the woman is pregnant, then they have to make some kinds of the prenatal visit around the 6 to 8 weeks of the gestation, and that they have some kinds of the diagnosis. They had that diagnosis of the pregnancy, and then ultrasound and another ultrasound. And if the expectant mother is considered have some kinds of the risk factors like previous experience of the congenital disorders or any other kinds of the risk profiles, then the OBGYN doctor ordered some type of the invasive prenatal testing, so which is called amniocentesis. So amniocentetic water is pulled out and it's going to be screened. And this is still kind of the diagnostic test. And at that point, non-invasive prenatal diagnostic testing was not exist at that point. So this is Caitlin. So Caitlin was born in 2017 while I was a research fellow of the University of Utah. And what we experienced was when my wife had Caitlin, my wife already passed the 35-year-old age cup. So now she started to be classified as some kinds of the high-risk expectant mother. So before, when we had Aiden, if that was the situation, the doctor probably ordered the invasive prenatal testing directly. But in 2017, so I think it was around the year of the non-invasive prenatal diagnostic test started to be covered. So the medical doctor asked us or recommended us to receive non-invasive prenatal testing, and this is it. So the mechanism or some kind of algorithm of this study, this test administration is, so this non-invasive test was considered to become a replacement for the invasive test. At that point, it's actually not a replacement, it's a screening tool right now. And the pregnant woman with some kinds of the high-risk profile can receive this test based on, for testing the fraction of fetal DNA circulated in the mother's bloodstream. So it's non-invasive for the baby or non-invasive for the amniocentetic fluid, just kind of the blood draw and the test, and it generates the risk scores of having Edwards syndrome or the Down syndrome with this high sensitivity. And some monosomy X 92%, it's a little bit debatable. And in terms of the sex gender, it's almost accurate. So we got tested, and Caitlin was normal, so my wife did not move forward to the invasive testing. It seems like clinically utilized. And interestingly, so you can see the Walker, Brandon Walker, and the Robert Schmidt. So Rob Schmidt, he was one of my research mentors when I was a research fellow at the University of Utah. And the Brandon Walker, the first author of this study, they already tested the cost effectiveness of this prenatal diagnosis before I moved to the Utah. And the assumption was patients should follow what was recommended by the non-invasive prenatal testing. So if the NIPT test result is positive, then it should be followed by the invasive prenatal testing. And there may be some kind of the early termination discussion between the patient, between the pregnant woman and the OBGYN doctor if diagnostic procedure confirms there is some kind of the issue of abnormality. And this is the cost effectiveness chart, and you see like majority of the scatter plot simulation demonstrated this test non-invasive prenatal testing, along with invasive prenatal diagnostic testing, can be cost effective. And the mechanism of the cost effectiveness was, for high-risk pregnancy, it can reduce the number of invasive prenatal diagnostic testing. Because, NIPT actually confirm if this patient need to receive diagnostic testing or no. For the general normal pregnancy, the purpose is to screen fatal abnormality. And if there is some kind of the issue detected, then they can make some kinds of early decision on the pregnancy termination. So there are two different kinds of two different study populations here, high-risk pregnancy versus normal pregnancy. But anyway, in high-risk pregnancy, we have to demonstrate, okay, the number of invasive prenatal testing may be decreased once this test has been administered for the specific population. That was basic theoretical background or basic assumption. And okay, now we have to consider the money. The cost was actually unknown, so nobody knows the actual cost. But when we was recommended to get this test for Caitlin, the medical doctor said, okay, your out-of-pocket cost might be, sure, that might be less than $100. And you can see the actual number here. Yeah. I actually bring the copy, so you can just confirm it.
Whoa. Confirm.
Wow.
Yep. And so this is a copy of the statement from the insurance company, and I received the same amount of bill from the diagnostic test provider. So we just got shocked and called the doctor's office. What happened? And the doctor's office actually called the provider, and we actually called the provider. Eventually, everything, okay, it's okay. So everything just become to the $99 for us. But this experience, my personal experience, helped me to raise the question about, is it worth it to be paid $8,000? Oh my God. So that is the point of studying this research question. And current American College of the Obstetrician guideline, the ultrasound with the non-invasive prenatal testing with confirmatory invasive prenatal testing is recommended, and NIPT itself is actually recommended for all pregnancies regardless of the risk. I believe the cost is now way less than $8,000, but still, in terms of the clinical utility, there might be some area that we have to raise the question or that we might have to answer for the question. So the reason why...
Kibum, can I ask a question?
Okay, yeah.
Just to make sure I understand the non-invasive test, it's a blood draw.
Yes.
That is then run for basic presence of child DNA.
Yes.
Looking for anomalies, these trisomy anomalies.
Yes, basically not every single mother, every single expectant mother has a fraction of the baby DNA in their bloodstream. So it's extracted and tested.
$8,000 seems like a lot of money for a test like that.
Yeah.
I guess I don't understand the technology that it takes to draw the baby DNA out and maybe look for the abnormalities, but seems like a big chunk of money.
So, I mean, that is kind of the part of the shared decision making, because, if somebody's pregnant and they expect a new baby and they are willing to pay whatever they can do, right? So that is kind of the marketing strategy. And I believe now the price for testing the common abnormality is not that much expensive. But there is another part of the non-invasive testing. So Edwards syndrome, Down syndrome, it can be covered by the $1,500 or $2,000. But the rest, the rare condition, it actually generates another market with the low sensitivity. I'm going to point out that at the end of this slide, and the New York Times article actually pointed out that as well. So let me go back to my presentation. No, you're fine. So So because we do not have complete understanding of the utility since this is screening, not actual diagnostic or like companion diagnostics. And also, as I said, ultrasound, this is a part of the standard test. So everyone gets this ultrasound test, and based on the previous ultrasound technology, the prediction and the sensitivity of predicting Down syndrome or Edwards syndrome is still close to 90%. So it can rule out some needs of the additional NIPT, and probably non-invasive prenatal testing can be ordered for certain small number of patients, not of every single pregnant woman. So that is my base hypothesis or idea. And now the resolution of the ultrasound becomes better and better and better. So we have to consider what will happen. And we have, and we means my wife and I, Claren, she was also adorable.
What?
I mean, after she passed the her birthday, oh, it's nightmare started, sorry about that. So, when my wife was pregnant for this number 3 baby, I had a chance to work with the chair of this pharmacotherapy department of the University of Utah, and he was actually interested in the clinical utility of the certain test for the stroke population. And then what we found from this study was within the patient had a diagnosis of the stroke, thrombophilia testing is or does not have to be utilized because the utility of this testing for that population is not that high as we anticipated. So there are large number of subjects who did show non-utility of this test because of on anticoagulant clinic, or the test itself is not recommended for them. And some patients, they receive a duplicate or triplicate test, and they discharge before the hospital. They discharge from the hospital even before they get test results. So all the clinical scenarios are related with non-clinical utility of specific diagnosis, and it's just a waste of money. And now we have 4. And you know what? There was interesting story. I can just talk to you guys about what happened for this Ryan. But when we had Ryan, it was 2021, and we actually realized that Ryan had some kinds of the sign of the abnormality from ultrasound. So it actually generates the needs of diagnostic screening rather than non-invasive prenatal testing, right? NIPT is a screening tool, not a diagnostic. And I mean, the Ryan is healthy and well alert and well-growing baby right now, so we do not have any concern on him. But at that moment, okay, so everyone just hurt me. I was really extremely stressed out. What's the right decision? What is the wrong decision? And the screening process or the diagnostic process I received from the University of Utah was, okay, there was ultrasound, and I believe this one should jump to this fetal echocardiography or the amniocentesis directly without this one. But anyway, at that point, NIPT was a part of the standard practice. So anyway, they ordered this one and received another ultrasound, and we were referred to the fetal echocardiography and then received the amniocentesis invasive prenatal testing. So my wife received all the tests. And eventually, this one raised me question again. Did non-invasive prenatal test results actually influence any follow-up clinical decision? Because we confirmed we need this one here. So probably these 2 steps may not be necessary. Then, okay, probably now is the point to think about running a small exploratory study. So myself and my colleague at the University of Utah run the small-size observational research using the retrospective database obtained from the University of Utah Healthcare and Enterprise Warehouse. And it was basically solely based on the ICD code and the procedure code because of the nature of this study, I did not want to talk to the clinician or, genetic counselor. If I talk to them, probably they hate me, right? So, and that this is the study performed within the college pharmacy. And the question was, does NIPT mitigate concerns from invasive prenatal diagnostic testing? Exploratory research. Okay, background. I've already introduced this one before. So NIPT showed promise in reducing unnecessary invasive medical procedures, but it associated with high upfront cost to healthcare plans, as you see. While NIPT has upfront costs, implementation of this procedure has the potential to reduce unnecessary medical costs and the potential maternal or fetal harm because it can provide a chance to avoid invasive prenatal testing. And in a high-risk pregnancy, NIPT can reduce the number of unnecessary invasive tests by 95%. So this is basic assumption used for previous model-based cost-effectiveness assessment. So I would love to take a look at, is this true in the clinical scenario? Oh, hypothesis. Okay, if that is the truth, a negative association among the high-risk pregnancy population, a negative association between the order of the non-invasive prenatal testing and the frequency of invasive diagnostic procedure has to be demonstrated within the healthcare system. And this should be the strong signal of the clinical utility of the non-invasive prenatal testing. And it proposed the observation research using the University of Utah Health Data Warehouse. And I want to point out this one here. So probably it would be better to pick the number of the early pregnancy as a final outcome. The reason why I was not able to do was, in the University of Utah healthcare system, once the doctor decided some kind of the early termination of the pregnancy, the surgery is generally not performed in the University of Utah healthcare system. So it's just kind of the community healthcare setting usually perform that kind of the surgery. So that is why I tested number of NIPT and the number of the invasive diagnostic testing within the limited number of patients, high-risk pregnant women. Okay, method. Usually, the pregnant woman see their doctor around the week 6 or 8, and the end of the first trimester window is 13th week of the gestational age. And then non-invasive prenatal testing. The window placed between the 10th to 21st week, but it usually happens before the 15th week because the doctor should consider some kind of the chance of the invasive prenatal testing. And the IPD window, this is recommended between week 15 to week 18, but technically it can be performed within week 11 to 18. So patient follow-up time frame for this retrospective observation research is, whenever it happened, first visit with pregnancy with the indication of the first trimester, and we follow that patient for 90 days. And all the patients made at least 3 follow-up visits within 90-day time frame to confirm that they were continuously followed by the doctors in the University of Utah healthcare system. Then we actually excluded the multiple gestation because it actually decreased the sensitivity and specificity of the non-invasive prenatal testing. And the odds ratio of non-invasive prenatal testing to receive invasive prenatal testing was calculated using the data. And here is the result. We identified 551 pregnant women who received the non-invasive prenatal testing and 1,500 who did not receive non-invasive prenatal testing. Similar age, similar group age, and you can see the large difference in this one. So it's actually driven by socioeconomic status, right? Not the clinical decision or the clinical usage. And then if we break down the cohort by the number of patients who received invasive prenatal diagnosis versus who did not receive invasive prenatal diagnosis, then still you can see socioeconomic status is a big driving factor rather than the clinical reason. So after that, association between number of invasive prenatal testing with number of non-invasive prenatal testing is 1.1. And I just run some kind of the single covariate adjustment here, considering all variable, all covariate adjustment may create some kind of the dimensionality issue. So basically what this chart said, okay, we did not see 94.6% decrease in the utilization of the invasive prenatal testing within the high-risk population. So where is the clinical utility of non-invasive prenatal testing? Okay, we don't know. Nope. Okay. So in conclusion, non-invasive prenatal testing, based on the exploratory research, did not significantly influence the clinical decision on invasive prenatal diagnostic testing usage in a high-risk pregnancy population. And I mean, basically, it's clear both non-invasive and invasive prenatal testing were subject to the health plan. Basically, it's associated with the socioeconomic status. And it still generates a question about cost-saving effect or cost-effectiveness effect of IPD in the high-risk pregnancy and management, IPD as well as non-invasive prenatal testing. So because to achieve, based on the previous model, to achieve the expected cost-saving or cost-effectiveness, NIPT needs to achieve an anticipated decrease in the IPD by at least 66%. But I was not able to identify that. Sorry. Yeah, this is the New York Times article. I mean, this approach is a little different. I actually my experience was NIPT was okay, but ultrasound was not okay. Then what is the clinical utility of the NIPT? This is a little bit different story. I said there is the Edwards syndrome or the Down syndrome targeted NIPT part and the rare disease part. So for the patient who received this test to identify if their baby had rare disease or not, this non-invasive prenatal testing actually generated positive results. And diagnostic tests say, no, your baby is okay. Then what is the clinical utility of this one? So it's now being paid attention by the other sectors of the society and the doctors, but still it's under investigated. So my goal is generate a funded research program to demonstrate the clinical utility, and because the shared decision-making process is crucial and really important for the pregnant woman and the parent. So this may be part of my funded research plan, and I started communication with the doctor, the OB/GYN doctor, high-risk pregnancy OB/GYN doctor, and the Rachel, who is the genetic counselor. And probably this will help us allocate the resources from test without utility to clinically utilizable test in your future. And you know, so the research is not limited to this non-invasive prenatal testing part. And if we start to investigate this one, probably every single part of the clinical practice might have some kinds of issue with this one. So doctor just click, order it, and not use it, whatever it was. Okay, there was information. So we probably have to avoid that kind of situation and more kinds of the detailed approach about the planning, how to utilize the diagnostic test to direct your utilization of the drug, your utilization of healthcare technology. Okay, this is the end. Thank you.
Questions from our audience of people who went through the snow to get here to listen to Kibum, or questions from our virtual audience. Claire has a question.
So can you go back to the data where there's a patient going to the last one? This one, yeah. Sorry, the previous one.
Okay, this is the NIPT part. Yep.
Yeah, so I thought you said in the previous slide that all the high-risk women went through non-invasive prenatal testing.
Yes.
So for the patient that's here in the second column that doesn't have non-invasive prenatal testing, is it just because of the healthcare they have? Because I thought they all have to go.
So I mean, that is interesting question. The data, the time frame for this data extraction was from the October of the 2015 to 2018. So there was a little bit escalation of the acceptance of the NIPT within the system. So not everyone is covered at the point of the data collection. But at the end of the data collection, majority of population is covered. But the thing is that if we have the patient population completely covered, we cannot compare the patient who received this one and who did not receive this one. So there is intentional kind of expansion of the time span for the data collection and make a comparison group here.
Questions from our virtual participants? Let's see if. Go ahead.
Okay, Claire.
Oh, sorry, we did not. We'll need to restate Claire's question.
Okay, so sorry about that. Claire actually asked me about, okay, if the patient started to cover for this test, why I had a third or a quarter of patients received NIPT versus 3 out of 4 patients did not receive the NIPT. So my answer was, because of the creation of the cohort who received and who did not receive, I actually expand the scope of the data collection period from 2015 to 2018, not limited to the 2018 only. Yep, Claire again.
Are you going to explain this to like the non-high-risk women? They're not required to have the non-invasive renal.
Okay, so Claire's question is, am I going to expand this research question to the non-high-risk pregnant woman? Yes and no. So at this moment, I mean, basically, University of Illinois hospital and healthcare system is not, healthcare system does not charge dollars to any pregnant woman. So we can basically expand the idea, but we have to assess what is kind of the outcome we can measure. So my basic plan is working with OB doctors and as well as invite the bioinformatician to take a look at the tax record and see if there are any kinds of the information sources other than the procedures or other than the diagnosis code we can identify from the chart. That may help, but definitely I have to start from the high-risk patient because the clinical decision is or was made and intentionally made for that high-risk pregnant woman. And if we have larger number of patients, yeah, that is great, but outcome might be different. For example, low-risk population, we have to assess what is the number of the expected number of the early termination of the pregnancy without NIPT versus what is actual number of the early termination of pregnancy. That may be the outcome for the low-risk population, but for the high-risk population, the purpose is to reduce the number of invasive prenatal testing. So the outcome might be, in addition to the early termination of the pregnancy, what is the number of the invasive prenatal testing associated with utilization of the NIPT?
I thought Simon had raised his hand. Call on Simon.
Okay. Dr. Picard?
Kibum, I really enjoyed the narrative around your research, and I was wondering to what extent, and I'm not familiar so much with how payers act on this kind of research. What do you need to have some kind of action on the findings? Let's say with this smaller study that you did, let's say you validate it in several large data sets, and it's clear that payers are paying for something that seems unnecessary. Let's make that assumption. What kind of uptake can you get with these decision makers when you examine this in a diagnostic test? Is this largely a political, like, to make an impact on payers? You're basically doing them a favor, but is it politically unpalatable for them to say withdraw this test? Because I know that there was a lot of issues around mammograms and screening age. when it was found that it was not cost effective, despite the recommendations of a panel.
Thank you so much for raising that question. And if I have to make a clear-cut answer right now, probably I'm going to be stressed out. I do not have a clear answer for you. But I mean that, yes, it is really political in some manner. For example, like the patient advocate group or the pregnant woman advocate group or the ACOG group, they may be really kind of give a preference to the utilization of the more data or the more diagnostic technology. But probably payer may not. So the action, once this has been demonstrated, then the action might be, what is kind of the cutting line to define the patient who actually need this test, but who actually move directly from the ultrasound result to the diagnostic tool without non-invasive prenatal testing order. That's the only answer I can give it to you right now. Sorry about that.
So I'm going to ask a question similar, because I've been thinking about this too, because sometimes healthcare providers order a test because they're concerned about getting something right and not being subject to legal action.
Yep.
So it's a very conservative approach, right? I'm going to do more tests and more tests and more tests because I'm going to protect myself from some lawsuit down the road. And this approach of conservative medicine may lead to a lot of waste, clearly. And I wonder how that builds into the NIPT example or other examples of lack of clinical utility of tests. Is it really a cover your rear end kind of approach?
Yeah, so Todd asked me, okay, how we can incorporate the doctor's consideration on the conservative approach, possibly to avoid any kind of the lawsuit.
Yeah, great.
We probably have to talk to the JD. Yeah. I mean, that is interesting question again, but sorry, you know what? This is more kind of the political debatable approach or the answers. Unfortunately, I cannot have an answer for you right now, especially at this stage, and I just run the exploratory research.
It just might be something for you to chew on.
Yeah.
Another factor besides sort of cut and dry clinical utility. Does it change what I'm going to do? Is there are other decision factors that are coming into play, right?
Yeah.
That I think ultimately may influence, was there a response based on a test result?
Yeah. I mean, you know what? I can scientifically justify it myself.
Yeah.
Like, yeah, we have the diagnostic tool in addition to the screening tool, and definitely the positive predictive value of the diagnostic tool is close to the 99%. If that is the case, why we use the NIPT if it's not utilized for the clinical decision? But yeah, but I completely agree with you that from the doctor's perspective, who have to make really kind of the conservative decision, yes, it's really hard.
Yeah. There's another question in the chat, Kibum.
Do you know it compares the U.S. in terms of the frequency or circumstances?
I'm saying, do you know how they if they use these tests in Canada? If you do know that, do you know
No, I'm sorry.
the frequency or circumstances in which they use these tests are?
I think there was one study performed in the European country, and they said minimal utility or no utility. But I have to take a look at the another country data. Thank you.
And with that, we are out of time for today's seminar. Thank you all for joining us virtually. Thanks for Nadia and Claire for braving the winter weather and coming here in person, and to Kibum also. You can have your bill back. I don't want anything to do with that. We'll see you all next week. Stay warm and safe, everybody.